Good afternoon, everyone. Thank you for coming. I'm delighted to host this first of hopefully many series of webinars on the field of oncogeriatrics. This being obviously the first session covering managing cancer in older patients. Of the hopes of this webinar of today is to provide you with an overview of the care of the considerations that we need to take into in managing cancer in older patients. My name is Cassandra Ng. I'm a consultant geriatrician based at Wythenshawe Hospital with a special interest in geriatric oncology, and I'm also the co-chair for the British Geriatric Society Special Interest Group in Oncogeriatrics. So I'm just going to start with my first talk on setting the scene, really, with regards to oncogeriatrics in the UK and the current state of play. So just my conflict of interest. As you know, for the agenda today, we've got 4 talks, starting with myself setting the scene, and then we've got a talk on social frailty, designing services for older people with cancer, and then finally with researching older adults with cancer. So the aim of my talk, my very brief talk, I'm just going to talk a little bit about why this is important, introduce the concept of frailty, which most of you probably already know, talk a little bit more about the new frailty guidance that was launched nationally last year, and then touch on the current services that we already know is happening in Greater Manchester. And we'll have a discussion at the very end after all the speakers have completed their talks. I would encourage you to pose your questions as we go along, and we'll try to cover it all at the end. So I think this goes without saying, everyone knows this, that the population is aging. And we are starting to see more and more older patients in our clinics. And we're going to see more of that in the near future. And this means that for oncology services, really, that we're going to see more patients with geriatric syndromes. And traditionally, there were 4 kind of geriatric syndromes, which geriatricians, kind of consider as the bread and butter of geriatric medicine. So things around immobility, impaired intellect, incontinence, and instability. But more recently, we see more of the concepts of things like frailty, sarcopenia, anorexia of aging, cognitive impairment, polypharmacy, and intolerance of medicines. And I'm sure all of you in clinical practice would have encountered some of these patients, be it in A&E, in the outpatient setting, in general practice. And we know that currently around 10% of people aged 65 years and above live with frailty, some degree of frailty. And this will continue to rise in the coming future. And those over the age of 85, we're seeing probably up to 50% of the population living with frailty. So I think all of us working in cancer will not escape seeing this cohort of patients. And the realization within the cancer setting has come as far back as 2012 in the UK with this Macmillan report about care of older cancer patients in the UK. And at that time, they were talking about 36% of cancer cases being diagnosed in the age group of 75 and above. I think that's probably far higher now. Probably safely to say that 1 in 2 cancers diagnosed now is in the older population. And we know that our cancer outcomes at that time were far behind our Western counterparts. And if we were on par at that time, we would probably have had 15,000 fewer cancer deaths a year. Older patients also themselves reported inequalities in their experience of care, and they were less likely to receive effective treatment. The Cancer Research report in 2018, Advancing Care, Advancing Years, also highlighted this about the need for older patients to be considered in all new cancer services, including the use of geriatric assessments in older patients with cancer to produce a more holistic picture of an older person rather than just relying on performance status. And we also talk a little bit at that time about research, about recruitment of older people into cancer trials. So before I go on about the frailty guidance, just a little concept about introducing what frailty is. So the British Geriatric Society talks about frailty being a distinctive health state related to aging, in which multiple body systems gradually loses their inbuilt reserves. So therefore, they have less ability to cope with everyday acute stresses. And this means, in the simplest terms, that their response to stresses may be worse than another person. So someone who's relatively fit may recover quite promptly, but those at the end of the spectrum, so someone with severe frailty, a simple stressor such as an infection, cancer treatment, can very quickly lead to negative outcomes. And I think at this point, I really want to emphasize that frailty is a spectrum. So you're not either frail or not frail, and there's no cutoff points. I think it is a spectrum. You could be fairly robust, you could be mildly frail, moderately frail, or severely frail. And there's some kind of reversibility in some stages of frailty. And we know that frailty as a concept is not just related to aging, but it has interplays with things like chronic diseases, disability, although in separate entities, there are some overlaps. And we know that cancer as a disease extends one state into potential frailty, be it cancer itself, the progression of cancer, or cancer treatment. And I'm sure we've seen this ourselves in our practice. And I think really you may ask why this is important. And I think I see it in the simplest terms. I think the general principles of management of older patients, first and foremost, we need to kind of briefly categorize them into whether they are a fit older person, for which you would proceed with treatment with the best chance of cure and optimize them where we can. Then there's a severely frail, for which is fairly clear that best supportive care is in their best interest, and that in this cohort of patients that we involve palliative care, for example. But a majority of older patients that we see in clinics are those who are maybe, and in those cases, we need to think a bit more via the use of frailty screening, comprehensive geriatric assessments, or any geriatric assessments to think about, what's their pre-existing life expectancy, irrespective of their cancer, and what is treatment going to bring for them, and managing their expectations. And we know in Greater Manchester, we have excellent palliative care services. We've got a prehab for cancer team who helps optimize one's nutritional and physiological state. But then we've also got oncogeriatric services around about in Greater Manchester, and I'll talk about that in a minute. So in the UK at the moment, so what's happening in the UK is the Macmillan report was in 2012, and following that report, there were more and more pilot kind of services up and down the country. But as of 2020, these are the oncogeriatric provisions in the UK. You can see they're still scattered up and around England, Scotland, and Wales, but probably not enough of them. And the services range between kind of specialized oncogeriatric services, be it led by geriatricians or oncologists, and in some areas around kind of upskilling oncology services in frailty management, so kind of education around those areas, upskilling various AHPs within the team, the cancer teams, to do their part in optimizing older cancer patients. And then in some services where people are being screened for frailty and referred on to geriatric services. And in 2023, so this is what we are particularly excited about, is the launch of the RCR, the joint RCR, BGS, SIOC, and Macmillan report guidance on implementing of frailty assessments and management in oncology services. And in this report, it touched very clearly that frailty is everyone's business. And to be able to succeed in optimizing cancer care for older people, we will have to upskill all teams, not just relying on geriatric services or prehab services. And it recommends that frailty screening or frailty assessment needs to be considered, and it goes as far as all adult patients with cancer, because we all know that frailty is not only in the older patients. We have 55-year-olds, 60-year-olds who are also frail, but to really consider this in all adult patients. And it is to be done as early as possible in the cancer pathway, particularly at presentation or even with kind of at the point of referral. And we know our primary care colleagues have already measures in place within their systems to highlight patients who are potentially frail. And then the key point of treatment, it's really important that we reassess frailty, because as I mentioned earlier, that patients can become more frail with cancer treatments, and some of this may be reversible. And it can be performed by anyone who is trained, so not just the medical team, not the nursing team. It could be the radiographers, AHPs, and any of our colleagues who are trained in frailty assessment. So how do we do this, you may ask? And I think the guidance talks about two main approaches. So the initial one is of just a simple frailty assessment to identify vulnerable patients. If you don't have any time, at the very least, consider doing a frailty assessment. And this would take you less than 5 minutes. And we recommend there are lots and lots of frailty screening tools out there, and the ones we recommend is the clinical frailty scale. The reason for this is because that's a universal language among kind of geriatricians in acute care settings, within emergency department, everyone in perioperative care as well, that everyone knows what we're talking about when we talk about the clinical frailty scale. But particularly in cancer research, there's not much evidence as yet with regards to use of the CFS, but certainly all the frailty screening that's been used in the research setting, cancer research setting, is with the G8 score, which is the one on the right of your screen. And that's an 8-part score, and you would score them accordingly. And if someone's, kind of 14 and below, they could potentially be frail. But what we have found in clinical practice is that the G8 do tend to overestimate frailty in the cancer cohort. I talked a little bit about CFS there. The clinical frailty score is heavily validated in care of older patients generally. And we know that the higher your CFS score, your risk of mortality and dependency increases, and it is clearly illustrated in the graph. And we know that our team in Newcastle have started using CFS in cancer research, and they have also started pulling data through to say that actually it is also a good prognostic marker in older patients with cancer. So the next approach we recommend is a multi-domain frailty assessment. This takes, we appreciate that this takes a bit more time, but this will hopefully identify and manage a range of frailty-related issues. And on the right of the screen here, I kind of show you briefly the differences between that. So you've got the initial step of frailty screening, very simple approach, takes very little time. You can then do a little bit more detailed assessment, which is a geriatric assessment, or we could do the more comprehensive assessment of an older person, something that is done in all geriatric services, which is a comprehensive geriatric assessment. And I'm just going to take you through very briefly what examples of this. So geriatric assessment, and in the literature, you will see a lot of kind of cancer research in older people talking about geriatric assessments. And that's kind of a multiple geriatric tools that you can use to assess different areas, different domains of an older person. And they will cover areas such as, kind of toxicities, chance of toxicities for chemotherapy, the nutritional aspects of a patient, the mental health, cognition, or around things like sarcopenia or their comorbidities. So they can be done in isolation to each other to give you a bit of an idea, a bit more holistic idea of the state of an older patient that is in front of you. But the gold standard assessment and management of frailty really is the comprehensive geriatric assessment. This will take, unfortunately, time and usually involves the roles of the MDT. And when I say the MDT, I mean our nursing colleagues, the AHPs, social workers, sometimes speech and language therapists, dietitians, multiple members of the MDT. And this is a comprehensive assessment that looks at all areas of an older person, ranging from physical health all the way to managing or reviewing their medications. And this will lead to obviously creation of a list of things that we need to tackling them individually with the patient, and then delivering interventions. And that could be as simple as, giving advice about fortifying their meals, which I know a lot of our cancer specialists already do that, or falls prevention, measuring long-standing blood pressures, involving therapists with regards to home adaptations, or exercise programs. But they're all individualized to the patient in front of you. And there needs to also be regular plan reviews of these patients. And they don't necessarily have to be a medical review. It could be with our pharmacy teams, with our nursing teams, or our therapists. We know that the comprehensive geriatric assessments are already used widely within geriatric inpatients, geriatric outpatients. but more so in other geriatric liaison services, such as autogeriatrics, frontal frailty, in surgical liaison, and the community. And we know all this reduces the length of stay, unplanned hospital admissions related to frailty, and reduces discharge to 24-hour care, which is sometimes a priority for another older adult and more important to them than actual survival. And increasingly, there are more and more kind of research coming up showing the benefits of comprehensive geriatric assessment in patients. And locally in London, the team at King's College have shown that the use of geriatric assessment led by a geriatrician has reduced toxicities and increases completion of systemic anti-cancer treatment. But worldwide, you can see on your screen there that there are more and more data coming through that it does reduce toxicity and improves outcomes in these patients who are having systemic treatment. We still do like research around areas such as, kind of immunotherapy or the upcoming targeted treatments, and also things like radiotherapy. And I think certainly there's a need for the research within those areas. And the guidance also goes on to talk about the intended outcomes of doing this. So we talked already about how assessments of frailty and more holistic assessments can give you a better idea of one's state, but also to guide decisions about what treatment we're giving patients or not give. And sometimes that's the right thing to do. We talked about the optimization of frailty-related issues through our MDT colleagues, but they also touch about working more closely with primary care, because some of these things our primary care colleagues are already excellent at doing, so nutritional states, and some GP practices have their own physiotherapists on board as well, involving the wider MDT, and then touches also on areas about in which cases you would refer to special services. So I would encourage you to read this guidance. I think it's only about 20 or 30 pages long. It's quite simple to read, and probably you'll get through it in 10, 15 minutes if you're interested. I'll put the link in the chat in a bit, just to have a look. But the last bit I would touch on the guidance is about audit and research. And we know cancer services, cancer research is something that most are interested in, but unfortunately, all the patients are often underrepresented in these clinical trials, be it because of their cognitive impairment or their comorbidities. And I think there's a real need to start thinking about how we incorporate these patients into clinical research, but also considering other outcome measures, because of course a lot of research looks at the risk of toxicities, the risk of the mortality rate, but actually in an older person who is 80, 85, really mortality may not be the best marker of outcome, and the guidance suggests some other measures, outcome measures, as demonstrated on your screen there. And I think it's something we as a team needs to start thinking about. And there are also some national recommendations within the guidance, and talks about incorporating this into the National Cancer Plan. And certainly working with the BGS, we have incorporated some of these areas, and they were taken up by the Scottish government in their recent Scottish cancer strategy. And it's something we're hoping to start pushing forward within England and Wales as well. And with regards to also with frailty assessment as a KPI, and considered in all referrals and MDT discussions. So Greater Manchester, so actually we are fairly ahead of the curve in Greater Manchester with regards to oncogeriatrics, and you can see that some of the works have already begun before the introduction of the national guidance. And I've just demonstrated a few of the works that's been done in recent times. So I think in 2017-18, we've piloted the oncogeriatric service within the lung cancer services at Wythenshawe Hospital. This went on and developed into a full service in October 2018, a fully funded service led by a geriatrician. In 2018, at the end of 2018-19, the Christies participated at a specialized clinical frailty network project with regards to introduction of clinical frailty score implementation within all their new lung cancer patients, and that was very, very successful, and that continues to today, that the new patients have CFS screening. In June 2022, GMs funded the incorporation of oncogeriatric services within the one-stop lung cancer service, and in July 2022, the senior adult oncology service within the Christies, covering multiple disease groups, was formed. and that's still ongoing to today. I've also heard of kind of various initiatives up and down GM, so things around like virtual wards within Tameside, the use of Macmillan Cancer Care Coordinator in Macclesfield, though I know strictly not within GM, but the use of also frailty nurses to help within oncology settings. So we are fairly ahead of the curve, but there's certainly more work to be done. As I appreciate that a lot of this are happening kind of down south, within kind of South Manchester and the Christies itself. And part of kind of doing more works involves also education, and that's part of the reasons why we've decided to start with this series of webinar. It's incredibly important that we educate or raise the profile of oncogeriatrics within GM. And following this webinar, we will have a second series in March, the 7th of March, to cover aspects of what each AHP or nursing colleagues can do to help and play their part with regards to optimizing care for older cancer patients. Then we have a practical skills in geriatric oncology study day organized by the Christie School of Oncology on the 7th of it's in April 2024. So if you're interested, please do sign up to that. And we've also been going around to various different MDTs and kind of webinars and local meetings to kind of promote the care of older people with cancer. So really, all I really want to say really is that we really need to start thinking about frailty screening in adult patients. But there's no point screening if we're not going to do anything about it. So if you do plan to screen your patients and put the pathways in place, then thinking about what needs to be done following that. Some of us are fortunate to have oncogeriatric services, and in those cases, they can be picked up by then. But then if we do not have the funding for oncogeriatric services, it's just thinking locally about what we can do, working together with geriatric services, or thinking about empowering all members of our MDT to do a little something for the patient, and that would make a huge difference collaboratively. And certainly there's more research, education, audits that's needed within this area. So for those who are interested, there are some resources here that I would like to share with you. So I talked a little bit earlier about the training of any team members to do clinical frailty scores. And on bullet point 4 there's a link of a training module, which is really, really good. And I would encourage you to look at that. But otherwise, there are societies like the International Society of Geriatric Oncology, the BGS Special Interest Group, and the National Forums of Oncogeriatrics. And Naomi, who is going to speak later this afternoon, leads on that. And I think she said she's happy for you to contact her if you wish to join this forum. There's a forum of everyone who is interested in doing something for older people. You don't have to be part of a all singing, all dancing oncogeriatric service. You could just be interested in doing something, a little something within your current scope of practice to improve care for older people. And there is just kind of to let you know there will be an oncogeriatric module on the BGS website coming up for those who are interested as well. But at the moment, there are already existing modules that you can work through within frailty and perioperative care, which obviously has links and relevance to care of older people with cancer as well. So thank you very much. That's just it from me. That's my email address on there if anyone wishes to contact me to talk about anything with regards to this oncogeriatrics, really. So thank you very much.
So, good afternoon. My name is Jenny Woods. I'm an occupational therapist at the Christie. My role at the Christie is as a Macmillan dementia and frailty specialist, and I'm also a professional doctorate student at the University of Salford, where I'm researching social frailty amongst adults who are living with both cancer and dementia. And I'm also the chair of the Royal College of Occupational Therapy section, specialist section for major health conditions. I'd like to thank the organisers for inviting me here today to talk at today's session. It's an honour to be part of such a great event and the opportunity to talk about something that I'm so deeply passionate about. So, today I'm going to be talking to you about social frailty as an emerging concept in oncology. And my interest in this area came from my clinical practice as an occupational therapist and my role as a dementia and frailty specialist, where I'd hear stories about from patients of all ages who'd undergone cancer treatment and they've had to stop their social activities or withdraw from social roles, and in some instances, make significant life adjustments which had an impact on their mental health and also their quality of life as well. But also the importance of social support networks for older adults who are undergoing cancer treatment have really come across within much of our work as a dementia and frailty specialist, and how older adults will often rely heavily on these social support networks through their cancer treatment journey. There's a couple of cases that have really stayed with me throughout my professional career. One of them being a 72-year-old lady who was undergoing radical radiotherapy for head and neck treatment, and she also had a diagnosis of dementia. And before she started treatment, she was living at home with her son and her pet dog as well, and she was very socially active in her community. She didn't have a package of care, and she was managing reasonably okay with the support of her son. And partway through her treatment, she became to the point where she needed a hospital admission because she was struggling to swallow and wasn't taking in the nutritional support that she needed. And ultimately, she needed a rig feed as well. And also throughout the cancer journey, that it was that her cognition had deteriorated as well. And this combination of these factors meant that she was unable to return home and ended up moving into a 24-hour care setting. And this lady experienced a number of social losses in respect of her living accommodation, her her social activities within the local community, and also not being able to be with her pet dog and living with her son as well. And that's always stayed with me, with those social losses, and I've often reflected on this case, and throughout this presentation I will refer back to this case study. I think it's important to acknowledge before we go through the presentation is just there is limited research. This is an emerging area, the concept of social frailty, and very little evidence relating to the concept of social frailty in oncology. So today I really want to focus on, I guess, sort of using it as a bit of a presentation, as a bit of a critical appraisal of thinking about why we need to be focusing more of the social aspects of frailty and the social aspects of health, and thinking about how it will support our old adults who have got a cancer diagnosis. So there's four aims of the session that I'd like to be able to cover. The first is about thinking about those social factors and how they influence cancer outcomes, and thinking about setting the scene. And then I'm going to think about what is the concept of social frailty. As I said, it is an emerging concept, and I'll go through a definition. And I'd like to take some time about thinking about that intersectionality between social frailty and physical frailty. I think from the presentation for Cassandra, we're very familiar with the concept of physical frailty and some of those geriatric syndromes, but how do the two concepts relate together? And then I'll think about why we need to look at social frailty screening in cancer care as well. So, to start off with, I thought it'd be good to think about why we need to understand social frailty and really examine the social factors and health. There's been growing international interest in social factors and health in recent years. We've seen high profile reports such as Marmot and the World Health Organization highlighting that social determinants such as income, food insecurity, ethnicity, education, where we live, and housing can all influence health equity in positive and negative ways. And these social determinants have also shown to influence health outcomes as well. And there's also been strong interest in social health in respect of recognising social roles, social participation, the power of social connection and communities, all of which can play an important role in building a person's resilience, improving their quality of life, and improving the person's mental health, and potentially act as a protective factor for adverse health outcomes. And social prescribing, which was a key component of personalised care in the NHS long-term plan, sort of embodies all of these social factors to promote health and well-being. For older adults in particular, enhancing social participation is key to improving their general health and is often seen as an indicator for successful ageing. And I think another consideration for the need to consider social frailty is that there's been a change in many Western health policies where there is this increased reliance for individuals to rely on informal carers such as family and friends to provide a range of support, from practical, emotional and informational support. And it makes us question what happens if the person doesn't have these good support networks. What would be the impact on the individual? And I'm sure this may be something you may have come across in your clinical practice before. But for me, the thing that really has brought home that relationship between social factors and health is the COVID-19 pandemic, where enforced lockdowns and social distant measures disrupted our normal social patterns and activities. Social distancing measures and enforced lockdowns, particularly in that first lockdown period, meant that many of us, we experienced a loss of social activities or maybe change in social roles, reduced social contact or the loss of loved ones, which all had the potential impact our health and well-being. And there has been quite a bit of research attention looking at the impact of those enforced the social distant measures and the lockdowns. And the research that has followed has shown that as a consequence of people of all age, and this was for all ages, not just for older adults, but for the impact of social distance and lockdown measures, and meant that for some individuals they experienced a decline in physical activity, muscle wasting, functional dependence, cognitive decline, depression, anxiety, malnutrition, and accelerated sensory loss. And I guess it really highlights why we need to think about that intersectionality between physical health and social factors as well. I think when we look at those, the consequences of those social isolation and those lockdowns, many of those outcomes, those factors such as functional dependence, cognitive decline, depression, anxiety, we know that they're potential risk factors for adverse health outcomes for older adults with cancer. And again, just really highlights the need to consider why we need to think about social factors for older adults with cancer. So let's start to think about those social factors and think about, specifically why we need to focus more for older adults with a cancer diagnosis, and think about what the current evidence base is. Amongst the literature which explored older adults' experiences of cancer treatment, there's been repeated references to the side effects of cancer treatment, such as fatigue, neuropathy, continence issues, and a deterioration in strength, all of which can contribute to the individual experience social losses. And for older adults with a cancer diagnosis, in some studies have spoken about the need to prioritise the cancer treatment, but at the sacrifice of leisure and social activities. But they've also spoken about the need to rely heavily on family and friends for practical and emotional support. The area that does crop up a lot within the evidence base amongst older adults with cancer is that of social support. Social support is considered to be important for older adults being able to access cancer treatment. And we see here the reference from the cancer research document is that sometimes that we'll find that a lack of adequate support is a barrier to older adults accessing cancer treatment. In a study undertaken in America, it was found that 40% of older adults with cancer had an unmet social need. And the concept of social support for older adults is an interesting one, because research has shown that social support networks can be a protective factor for adverse health outcomes. There was a study undertaken by Chambers et al. In 2022, which looked at social support amongst older adults with a lung cancer diagnosis, and it suggested that social support might be a prognostic indicator for clinical outcomes. Other research has supported this by stating that individuals who don't have adequate social support or maybe they experience a lack of social connectedness, often will have inferior oncological outcomes, such as an increase in prevalence of cancer progression and a decrease in cancer survival. Similarly, social economic status for older adults with a cancer diagnosis has also been considered as a potential prognostic indicator um, for cancer survival rates. Um, those individuals with low social economic status at the time of diagnosis for older adults has been associated with an increased risk of overall survival. And I think another perspective to consider when we're thinking about social factors and older adults with cancer is about it's not just looking at it from the patient or the individual that's living with the cancer diagnosis, but also from the carer's perspective. For older adults with a cancer diagnosis, we know that they will rely heavily on informal carers, which may be partners, spouses, or other family members. But this increased demand on the informal carer has an impact, has a potential impact on their social aspects of their lives. Sometimes they will need to withdraw from social groups or social activities to support the individual who's living with cancer. All of this leads us into considering the concept of social frailty. So there are several definitions of social frailty, but the one I'm going to discuss with you today is the work of Bunt et al. Because it's the most recent attempt to define social frailty, and it's the definition that has attracted the most research as well. Bunt and his colleagues define social frailty as a continuum of being at risk or having lost resources that are important for fulfilling one or more basic social needs during the lifespan. Those resources include general resources such as education, finance, income, housing. Social resources are considered in respect of social support networks, their families and friends, and the social communities. And social behaviours and activities are focused on the social roles and activities that the person undertakes, as well as the person's self-management ability and the which encompasses their cognition and autonomy. Where a person's at risk of losing any or has lost any of these resources, they're vulnerable to becoming socially frail. We've talked through on the previous slide that there's been a focus for research and for policy to focus on social factors and social elements, but they don't tend to bring them all together. They've tended to focus on one aspect like social support or social economic factors. And for me, social frailty is an opportunity to view all of those social domains in one lens. There are multiple tools that can be used to screen for social frailty as listed here. All are quick to administer and therefore easily to embed in clinical practice. A bit like the Rockwood, it takes only a short amount of time. Some of these frailty screening tools have only got 5 items in them. Depending on which tool you use, there are maybe different elements of social factors that might be examined, but they tend to include a person's social level of social contact, their social activities, feelings of loneliness and isolation, as well as the person feeling they have a sense of purpose. It's been suggested that screening for social frailty should be done along physical frailty, and we'll explore this in a little while. But one of the benefits of this is about the fact that one study has suggested that using two of them together, like a social frailty screen and a physical social frailty screen, is that we can better detect disability and potentially geriatric syndromes. So, as I mentioned earlier, the evidence base for social frailty is very much in its infancy, but it is rapidly growing. Most of the studies that are available have tended to focus on community dwelling older adults. And when we look at the prevalence of social frailty amongst older people aged 60 plus, it has varied from setting and country. In one study, it was suggested that the prevalence of social frailty amongst community dwelling older adults is 18.8%, and for those in hospital settings, the prevalence increases to 47.3%. The evidence base, the research that is available, we can divide it into three main themes. The first relating to social frailty and other frailty domains. And the research that is available has suggested that often individuals are living with social frailty, they're often living with other domains of frailty, such as physical, cognitive, psychological. And I guess it really reinforces the need to look at doing geriatric assessments within clinical practice. The second theme that emerges from the evidence base is that social frailty can be associated with adverse health outcomes such as poorer mortality rates, increased level of depressive symptoms, decline in physical and cognitive function, and a decrease in functional independence. And I think we can take from this that it's potential we can use social frailty can be used as a prognostic indicator, but it also demonstrates the importance of societal factors such as social participation, social support, and social activities in enhancing and maintaining health and well-being. And then there are a couple of um, um, studies that have focused on the lived experience of social frailty. And these studies have really highlighted the importance of social support networks and relationships with spouses, children, grandchildren, and even pets in respect of enhancing our well-being, and also highlights that the loss of social roles and social activities can have a negative impact in have the person's sense of purpose and their social connectedness, and this can have a negative impact on their health and well-being. When we focus the research down into social frailty and cancer, there's only a handful of papers, but they draw similar conclusions of the research undertaken in community dwelling adults, that um, social frailty is potentially a predictor, and we can use it as a prognostic indicator for adverse health outcomes such as depressive symptoms and overall survival of patients with cancer. I think one of the interesting things is the prevalence of social frailty amongst individuals with cancer. It's slightly higher here than that of community dwelling adults. And it varies significantly from 27% to 46.8%. And there could be different reasons for this, and this might be due to socio-economic demographics, comorbidities, but also the staging of cancer disease as well. One study that I just wanted to draw your attention to, and I guess it really highlights why we need to think about social frailty screening. It was the work of Ono et al., and it was only a small scale study of about 195 participants. But within their paper, it highlighted and suggested that social frailty screening had a greater impact on overall survival than frailty alone. And I think, it is widely recognised within international guidelines that we need to be frailty screening for older adults. But I think this paper I think it suggests that we need to be not just doing physical frailty screening, but we also need to look at social frailty screening, and potentially the two would have a greater impact in terms of understanding the person's risk and understanding where they are in that frailty spectrum that Cassandra spoke about earlier. Over the next few slides, I just want to focus more on and think about more about the relevance of social frailty for adults with cancer and why we need to be screening for social frailty. And I'm going to start by considering this: social frailty and physical frailty, which come first? And I guess, does it matter? And the answer to this can be drawn from the evidence base. There is an acknowledgement within the evidence base that there's this reciprocal relationship between social frailty and physical frailty. but there's conflicting evidence about which one comes first. And we've got two studies that have opposing views. The work of Nagai et al. Used a 2-year prospective study of 342 socially robust community dwelling adults and identified that physical frailty was a predictor of social frailty. But in contrast, Magasako's cohort study suggested that social frailty preceded physical frailty. We've then got the work, another paper that suggests that actually, even though there is a reciprocal relationship between physical frailty and social frailty, which domain precedes which might be related to the age of the individual. And I think there's two reasons why we need to consider this and why we need to understand that one frailty domain might precede another. And it is around about being able to capture frail older adults. Cassandra in a presentation said that there is this spectrum. And actually, from when we're trying to look at optimising older adults through their cancer treatment journey, we want to try and capture them before they hit the frailty, before they hit the point of being moderately or severe frail. And actually, there is a paper that suggests that if we use a social frailty screen, we can potentially capture a wider range, a wider demographic, and potentially those that are not picked up by, from physical frailty screens. And this means that we could be able to provide earlier interventions for this group of patients. And secondly, we've talked about earlier in this presentation that social support networks and social economic factors are predictive factors for adverse clinical outcomes in cancer for older adults. And therefore, using a social frailty screening tool will mean that we're able to open discussions with the person and provide a personalised approach to care, and think about, as we've said, using a frailty screen to think about being able to identify potentially a wider range of modifier risk factors for the individual. The need to consider social frailty as well as physical frailty when supporting older adults through their cancer treatment is highlighted by the way that the two domains intersect. And I think as clinicians, taking a socially sensitive view of frailty means that we're able to address the person from a holistic point of view and offer more interventions earlier. I've taken this table from a paper by Quake et al., which gives us an overview and some examples of how social frailty domains connect with physical frailty domains and how they might present in clinical practice. And I think when I looked at this table, it really made me think and reflect about how I'm integrating the two domains in my clinical practice and thinking about how do we apply this to oncology services when we're supporting old adults. And I think the example that came to mind through discussions with peers and reflecting on my own clinical practice is about how we use exercise interventions, either to mitigate frailty in older adults with cancer, to improve their physical function, or to improve their muscle strength and mass. And it made me question, there is a wide range of evidence that shows that exercise is really important and has significant benefits. But how effective is it if the person's experiencing food insecurity and experiencing weight loss and malnutrition as a result? And made me think about how do we address this in our roles and our clinical settings and our services? What availability in our local areas are there for supporting individuals who might be experiencing this? And the second reason why we need to consider social frailty is about support and shared decision making. Shared decision making is a key component of personalised care, and as clinicians, we need to ensure that the treatment decisions are shaped around each individual's personal individuals and what matters to them. We know that undergoing cancer treatment can cause social losses for older adults, such as social activities, their social roles, their communities, and their social networks. And these are all important factors in shaping a person's identity and contributing to their social well-being and quality of life. For many older adults with a cancer diagnosis, they will often prefer to choose quality of life over quantity of life. And I take us back to the case study that I spoke about earlier. often wonder in that case whether it was explained to this lady that there was a potential that undergoing cancer treatment or the cancer diagnosis may lead to having to make significant life adjustments, such as going into a care home. What would her thoughts about this, not being able to live with her son, not being able to be with her pet? And I think it's really important to consider and to discuss when we're having those conversations. And lastly, I just wanted to leave you with this final thought that, and I guess we've touched along the way. But Bunt, in his work and developing the concept of social frailty, he did a study that focused on community dwelling older adults. And he came up with this. He said social frailty can be seen as a delicate balance of assets and deficits. And I think throughout the presentation, I hope that I've been able to sort of manage it. This is very much the case for our older adults who are going through cancer treatment. They are also potentially walking a tightrope of having social assets, such as their social support networks, their social activities, and their family and their support, but actually their cancer treatment and their cancer diagnosis and needing to attend multiple hospital appointments can cause those social losses, which can lead them into those social deficits. And I think what I'd hope to achieve by just drawing your attention to this, I think it's how we can support individuals to navigate their way through their cancer treatment. We tend to focus very much on physical interventions, but it's just as important to focus on the social aspects of their health as well. So I want to leave you with a few key points to take home with you and to reflect on. The first that I'd encourage you is to consider social frailty screening within your services. They are quick to administer, and as we've spoken about today, there are many benefits to using social frailty screening along other frailty screening tools to identify potentially a wider range of multiple risk assessments to inform um, shared decision making and hopefully to prove outcomes for this patient cohort. The second is that when we're considering social frailty, we need to acknowledge that it's not just one clinician who is able to fix everything for a patient. There needs to be a collaborative approach to addressing some of these social factors, and we need to have robust health and social care systems to support individuals and these populations. And lastly, we need more research in understanding the concept of social frailty. A lot of the research has been undertaken in community dwelling older adults and largely in Japan, but we need to understand the concept of social frailty more for older adults with cancer, so we can use this research to improve our patient care pathways, but also improve our interventions as well. I hope the session has been useful, and I hope to answer any questions that you have in the panel discussion later.
Thank you very much, Jenny, for such an enlightening talk. I think social frailty is not just an emerging area in oncology, but also within geriatric medicine. Certainly, I've learned a lot from that talk. So next up, we've got Naomi Farrington, who is the Senior Adult Oncology Service Implementation Lead. She's going to come talk to us about designing services for older people with cancer and what to consider when doing this. Thank you very much, Naomi. Over to you.
Thank you so much, Cassandra, and thank you also to Jenny for that really comprehensive overview of social frailty. I think we're going to be hearing a lot about that in future. So yes, I'm Naomi Farrington. I work in the Senior Adult Oncology Service at the Christie. My background is sort of in cancer services generally, both clinically and in research settings. So hopefully I can give a good overview of how to design services for older people with cancer and the sorts of considerations that you might want to hold in mind. Okay, so just a brief word about reiterating the impact of age in cancer. So we all know that older adults are more likely to have cancer, they're more likely to have additional needs such as comorbidities, and they're less likely to be offered anti-cancer treatment. And the upshot of this is that services just aren't designed for people with more complex needs. So how do we fix that problem? If services aren't designed for people with different levels of need, it means that a certain proportion of the population, and in this circumstance, older people with cancer, aren't getting what they need from our services. So one way to do this is to have dedicated services that respond to the needs of older people with cancer. So we tend to talk about geriatric oncology. I know that some people aren't keen on the term geriatric, but it was pointed out to me a little while ago that it actually refers to the stream of medicine rather than the patient themselves. So geriatrician is a doctor who looks after an older patient, in the same way that a pediatrician is a doctor who looks after a younger patient. And it's not about the patient. The name is about the doctor. So I like to continue to use geriatric for the time being, just because I think it describes quite well what it is that we're trying to do. But there are lots of different words and terms that you can use, and you just pick the one that you feel most comfortable with. So in terms of geriatric oncology models of care, there are lots of different ways that you can do it, but here are the three main models of care that have been employed and are being currently employed around the world. So I'll just go through these briefly. The first one is what we can describe as consultative. And this model is the one that we use here at the Christie. And in this model, the oncologist does a referral to the geriatrician, or the oncology team refers to the geriatrician, plus or minus an MDT to support, for a comprehensive geriatric assessment with recommendations, which may then inform treatment decision making, perhaps. But it's very clear that the oncological treatment decision making stays with the patient and the oncology team, so the geriatrician doesn't take over any aspect of the oncological care. In a shared care model, it's quite similar in that, once again, the oncology team refers to the geriatrician for a comprehensive geriatric assessment. But here the emphasis is on a shared care plan. So the geriatrician or the MDT is with the patient throughout their cancer treatment, and care is shared between the two teams, although still very much the oncological side of things is held by the oncologist, as you might expect. And lastly, the comprehensive model, which is sometimes viewed as a gold standard, but you can argue the pros and cons of all of these models. This is a very unusual model, partly because, well, mainly because there are very few sort of truly geriatric oncologist practitioners in existence. But in this comprehensive model, what happens is that both streams of medicine are kind of concentrated in this geriatric oncologist as an individual. So the geriatric oncologist is the treating oncologist throughout the treatment. So they not only hold the ownership of the oncological treatment, but they also manage all the frailty and geriatric concerns throughout as well. It's much more common in places like the US than it is here, just because of different training pathways for medics. But it's not something that we tend to see here in the UK. You're much more likely to see a consultative style model. So I will just talk a little bit about the senior adult oncology service here at the Christie, because I think it gives you an example of one of the forms of the models of care that we can employ. So the Senior Adult Oncology Service, after sort of building on the work of many individuals over the years, started sort of officially in the summer of 2022, with the aims of, firstly, supporting older patients and clinicians with cancer treatment decision making. Secondly, to support older patients to be in the best position to start the treatment. So in other words, optimising people prior to treatment. And then thirdly, which is by far the bulk of our custom, is supporting older patients through cancer treatment. So with whatever toxicities or concerns might arise during treatment as a result of the cancer, the treatment, or other comorbidities, for example. So we have a series of referral criteria, but I do want to stress that these are, first of all, these are iterative, these are changing, and also they are not strict in any way. They are extremely flexible. So overall, we tend to focus on patients who are age 70 or over, although, as we all know, there are many patients who are younger with complex needs, and we certainly consider taking them on as well. Generally speaking, we see people with a clinical frailty score of 4 or above, meaning they're vulnerable or frail. And this just means that having a slightly lower threshold here just means that we can sort of catch people sometimes before they tip into a frail state, because we all know that sort of effect that cancer treatment can have on somebody. Hopefully, the idea is that we get to them before that becomes the case. Most importantly, there has to be a clinical concern or a series of clinical concerns. So the idea is that our team is set up to really deal with complexity. So people with multiple issues, we don't generally encourage a referral from somebody, for example, who may just need the services of a dietitian, because whether this is the case or not, we feel that their needs can be met elsewhere by a specific service. The beauty of our MDT means that people can come to us with a series of concerns. So that's where our expertise lies. And lastly, we generally deal with people who have started or are about to start either systemic anti-cancer therapy or radiotherapy. So this is our multidisciplinary team. We have a few vacancies currently, but this is what we started with in July 2022. So Cassandra has been our geriatrician over the time that we've been open, and we also have, in terms of medical support, we have a GP who has a specialist interest in this area. We're also lucky enough to have a clinical nurse specialist, occupational therapist, dietitian, pharmacist. We've also had a physiotherapist, and our oncologist is our clinical lead, although doesn't tend to have input into the clinic itself. Tends to be there to oversee processes. So that's what we were lucky enough to start with. And of course, I am aware that not everyone will have access to these sorts of resources on their doorstep. So I'll say a little bit more about that in a moment. So this is our current process. As I've mentioned, we'll take referrals from the parent oncology teams. Currently, we primarily deal with patients with lung cancer. That's where we started our efforts, and we've moved out to also see patients who have myeloma, lymphoma, head and neck cancer, and we're hoping to expand in future to other tumour groups. Then what will happen is, after the referral is received, we operate a telephone screening clinic where our staff will call patients and ask some screening questions to really identify what sorts of concerns they might be presenting with and how best we might be able to meet those. And then if the patient is happy to do so, we invite them to come to one of our face-to-face clinics to provide a multidisciplinary assessment. These tend to be quite long appointments. A lot will happen at these appointments. But we really do try to make it comprehensive so that people don't have to return time and time again for the input of different members of staff. After that, the team will implement any interventions they see necessary and that have been discussed with the patient. And these usually include things like medication alterations, nutritional support plans, things like that, and make any onward referrals, for example, to the community falls team that might be necessary. And we also are very keen, of course, to pass on any recommendations or advice to the oncology team as well as to the patient's GP to hopefully sort of close that circle. So in terms of our activity and our outcomes over the first year, we saw probably about 150 patients in the first 10 months. And actually, I think anyone who's setting up a service like this needs to be aware that the volume of patients won't be huge, because it's quite, as Cassandra mentioned in her first presentation, it's quite labour intensive. The geriatric assessments do take some time if you're doing them in a detailed manner, and therefore it's not going to be the kind of clinic where you see sort of 20 patients in one afternoon. So I think as long as you set out to manage those expectations, I think that's very helpful. So in terms of patient, staff and caregiver feedback, 100% of all survey responses were positive. People really appreciated having access to this service. And appreciated having access to the wide range of clinicians and being able to generally come and see everybody in one day. They also appreciated a focus that was away from the cancer and took into account other health problems that they might have, which generally on their cancer journey they didn't get to experience. The team identified a wide range of issues, as you would expect, so from nutrition to mobility to polypharmacy and beyond. Early data does show some definite impacts that the team has had. Again, in geriatric services, it's really difficult to sort of really distill down where that impact, who's responsible for that impact and where that impact has taken place. Because there's usually so many services involved and so many other things going on with the patient. But generally, we can say that we've reduced polypharmacy, inappropriate polypharmacy. There has been some improvement in a continuation of a treatment plan, and by that I mean that greater numbers of patients have finished their planned course of treatment. So one of the problems we see sometimes is that patients will have cycle 1 treatment, experience toxicities which they're not willing to, aren't sort of satisfied to continue, or it's dangerous to continue, and then they have to cease treatment, which is obviously very difficult for the patient, but also for the system, it's quite a waste of time and money. So for everyone concerned, it's a lot better if we can help people, support people to reach the end of their planned treatment if possible. And also there's been a general reduction in the use of unplanned acute services. So for example, our admissions, unplanned admissions at the Christie have gone down with patients that we've seen. So it's not a perfect data set because we've had to use a sort of matched cohort system. And obviously, I think over the past few years, it's been quite difficult to collect comparable data because of the impact of COVID, etc. But the early results do show that the team has had a positive impact on many aspects of care and outcomes. So I hope we can continue to show that as we go forward. So we get asked a lot of questions, and I get asked a lot of questions about our service, and these three are probably the highest on the list. So the number one is, of course, how is it funded? Number two is, what data do you need to collect to sort of how do you prove the worth of the service? And thirdly, what resources do you need? Because as I've said, I'm aware that not everyone has access to this kind of range of resources that I've talked about today. So happily, Cassandra mentioned that we have the National Forum for Oncogeriatrics, or NFOG, which again, I'm very happy for anyone who would like to be added to the mailing list to contact me, and I'll pop you on. But essentially what we're trying to do at the moment is develop an online resource on the e-learning for health platform, which will kind of collate all the varied experiences of people who've been involved in setting up services for geriatric, for patients, older patients with cancer, and to sort of do a bit of troubleshooting, have some considerations of what people might need to think about, share experiences, just so people who are looking to set up those services in future can go on and get some ideas. And so we really hope that sometime this year we will be able to have a resource which can answer some of these questions, because obviously I could answer these questions for you today, but these are very specific to our service here at the Christie, and somebody who's in a different part of Greater Manchester or a different part of the country altogether will have very different access to resources and different needs. So please do keep an eye out for that resource. I will just say a little bit more about models that exist elsewhere in the UK. You've seen this graphic in Cassandra's presentation, and happily, I think that's now quite outdated. I think it's now populated by quite a few more services, but they won't all use the same model as we do here at the Christie, and for example, they do at Guy's and St Thomas' in London, or the Marsden, which are the other sort of centres of geriatric oncology. A lot of them will be very, very different, and so may not appear on maps like these. But just to share with you three of the different kind of variety of services. In Newcastle upon Tyne, you've got an absolutely fantastic, very dynamic occupational therapist, Jenny Welford, who was responsible for some of the data that Cassandra presented earlier. She and her colleagues have set up the lung cancer outpatient service at Newcastle, as well as a combined supportive care service at St Oswald's Hospice, and they see patients both at the hospital and at the hospice, so at different ends of the cancer spectrum, and they're made up of the OT as well as a physio, a palliative care consultant, and an associate practitioner. At Wythenshawe in Greater Manchester, as you will have heard from Cassandra, there's the one-stop geriatrician-led service for patients with lung cancer, and there's also the option for referrals to allied health professionals to make those really targeted interventions as needed. And I'm sure Cassandra will be happy to answer any specific questions about that service. And then another service that's developing very recently is that in West Suffolk, and that's run by a Macmillan Oncology Frailty lead nurse, and she's pretty much a one-woman band. She's very impressive, but has set up the service sort of single-handedly. She has access to a Macmillan AHP team, and I believe she's having an occupational therapist join her shortly. But she sees patients from a very wide area, because obviously somewhere like West Suffolk is pretty rural. So you can see what I'm talking about when I'm sort of trying to say that different areas will have very different needs to take into account. So that's just a snapshot of some of the variety of services that exist around the country. And it's really just to kind of reiterate Cassandra's point earlier that, you know, first of all, it's everyone's business, and second of all, you can actually do a lot with a little. So even if the only thing you do is to implement a frailty screen, well, actually that's quite a big step. So how can we ensure that services are designed to meet the needs of older people with cancer? I think probably the key idea that I really like to kind of hang on to when thinking about designing services is this idea of responsiveness. And this is just the idea that what we want is a service that can respond to different needs and have a way of identifying and meeting each person's needs and expectations, taking into account their personal goals and preferences. So you can hear that it has a lot of crossover with concepts of personalized care and shared decision making, but I just really like the idea that it provides a kind of goal from a systems point of view, from a service point of view, that a service needs to be responsive. So a little while ago, some colleagues and I at Southampton did some work really looking at how to better support patients with complex needs, and particularly dementia, who had cancer in addition. So we carried out a qualitative study looking at the experiences of patients, family members and staff in outpatient cancer services. And we really came up with a mnemonic which really just helps to hold some things in mind when you're thinking about particular services. And it's very straightforward, but it's clear. So there's a need to clarify needs, expectations, preferences, and goals. And as Jenny touched on, there's a number of ways you can do that, whether it's through a particular screening, whether it's through an HNA, having a particular tool, or whether it's just making sure that you have a conversation about needs, expectations, preferences, and goals with patients. Secondly, it's legitimizing these as valid. So asking the question, what matters to you, as Jenny sort of alluded to in her previous presentation, is just as important as checking on somebody's blood results, for example. It's going to have as much impact on their journey in our service. So we really need to see those things as important and valid. Thirdly, we need to enable these needs to be met by having strategies implemented, and those will vary from setting to setting. Then we need to audit to make sure it's working for patients, caregivers, and health service. We live and work in a very fast-moving environment, and we need to make sure we're keeping up with changes that occur. And lastly, we need to record for the future. So one thing that patients and families have continually told us they hate is saying things over and over again to different healthcare professionals, and this will just minimise the need for that. If anybody's interested, there's a link there to another Vimeo video, which just has a little animation to really kind of drive that home. And I won't spend too much time on this, but I just wanted to introduce the concept again of these theoretical principles. So people in healthcare tend to run a mile when I start talking about theory, theoretical models, but actually I think they can be really useful hooks to hang practical strategies on. They just help us to think about our services, why they are the way they are, and how they might be better. So one thing I'm very interested on is how we manage the dynamic of power in healthcare settings. So there's an obvious dynamic with the healthcare professionals and those in charge of the service holding a lot of power and the patient holding minimal power, which is obviously kind of exacerbated if the person is older, if they have multiple comorbidities, if they have cognitive impairment. There are many different things which might decrease the level of power and their ability to exercise power. And of course, I'm not talking about power in terms of who's physically the strongest. It's much more kind of capillary than that. But I think it's really important to talk about and think about ideas of power and privilege, how we can encourage shared decision making, use personalised care, help people to enhance their agency, so that they're actors in their own lives, and help people to navigate this very complicated discourse, which as healthcare professionals we sort of take for granted. We have our own language, we have our very structured environments that we sort of invite people into, and then expect them to have an understanding of what's going on. And actually it's up to us to really assist people to do that. And I've also included the wheel of power privilege, just to remind people that we might need to think about these kind of intersectional aspects when we're thinking about power dynamics in this setting. So really that's just to throw the idea out there and introduce it, and hope that you'll go away and think about some of these things in relation to older people with cancer. But really, I think these theoretical concepts marry really well with some considerations and strategies that we might use to make an outpatient unit more responsive to the needs of older people with cancer. So I've just put up here some really simple strategies that you might use to do this. So, for example, environment, making sure that the environment is dementia friendly. Obviously, there are lots of new things being built all the time, and we have to sort of ensure that they conform to these strict guidelines. But there's a reason for that, and it's because they genuinely do make things easier for people who have cognitive impairment. It helps to be prepared. So it helps if staff are aware when patients with additional needs are expected, whether that's regarding their mobility in physical terms or their capacity, so that they can put things in place for that. Continuity, we know how hard this is, but it's really important for the person to either see the same healthcare professional, if possible, or make sure that there's a key worker or navigator that can follow the patient through, so that there's some kind of strand that is continuous, and the person doesn't feel that they're just a number lost in a system. It's important to be flexible if possible. And this doesn't need to be a big deal, but for example, offering appointments at times that suit the patient, whether that's morning or afternoon, or offering perhaps virtual or face-to-face appointments that suit that patient's needs. Patient support, really supporting family, friends and caregivers, for example, enabling them and inviting them to accompany the patient. Jenny mentioned that sometimes we expect that, and we expect them to take on a lot of work, and we absolutely do. But the least we can do is therefore make it easier for them to support their relative. Work holistically. So as I've said, people really appreciate it if you don't only focus on their cancer, if you consider the other health conditions and the competing demands and burdens of symptoms and treatments that they might present. And then lastly, of course, information, giving information in a variety of forms, including easy read leaflets, and making sure that you check that understanding before you send somebody away into the ether. So those are just some easy strategies, I say easy, very blasé, that you might like to use or consider in your particular service. I have just provided some references. So these might be, if you want to follow up on the study that we did looking at improving the support for patients with dementia in cancer settings, then please do go and seek these out. They're all open access, so you should be able to get hold of them quite easily. And the last one is the one that talks more about analysis of power imbalance in an outpatient treatment setting, which I really love to write, and I hope you'll love to read it if you get a chance. I'm very happy to take questions. I'm aware that we're going to have a panel session at the end of our time together. But again, if anybody wants to email me separately, I'm also quite happy for that. So thank you very much for listening.
Thank you, Naomi, for the talk, and thank you for sharing your experience with regard to setting up services. You have, wide wealth of experience and knowledge within this area, so it's interesting to hear that. I would encourage anyone who is interested in setting up a service to contact Naomi, or if you're interested in a job in the senior adult oncology service, please do contact Naomi as well. It gives me great pleasure now to introduce the next speaker, Dr. Joe Taylor, who is an NIHR academic clinical lecturer at the University of Manchester, but also a specialist registrar in geriatric medicine at MFT. She's going to talk to us about research in older people. We've heard time and time again this afternoon about the importance of research in this cohort of patients to be more inclusive, including them, as well as in informing clinical services. So over to you, Joe.
Thank you, Cassandra, and thank you for the introduction. Apologies, I've had to decamp to my daughter's room, if you're wondering why there's a cot in the background. So I'm an academic clinical lecturer at the University of Manchester, and I'm also a geriatrician. My research focuses on frailty and heart failure mainly. So I look at remote monitoring data from cardiac devices, mainly around physical activity. So although I haven't done any research in oncology per se, I think a lot of the themes that I'm going to talk about across multiple disciplines. So hopefully I can share some of my experiences and highlight some of the barriers, but also facilitators to engage older people in research. So why does it matter? So as has been highlighted by many of the speakers, the risk and incidence of cancer increases dramatically with age. And I think research has probably been a little bit slow to catch up with this. And although we don't use age cutoffs in geriatrics, we know that patients who are over the age of 70 much higher risk of complex multimorbidity and frailty, and often have very high healthcare utilisation. So the need for research in this patient group is very high. And also the way that we treat these patients can be quite different. And I think everyone would agree there is multiple gaps in the research when we have patients in front of us in terms of therapeutic options in older patients with particularly frailty and complex multimorbidity. And I think, often we feel like we're a bit blind when we're talking to patients and their relatives and caregivers around therapeutic options for older people, because there are gaps in the evidence, and many of the large scale, phase 3 randomized clinical trials will not involve older people, for many reasons which we'll go on to discuss. So you often find that you're just having to use your clinical judgment and using phrases such as "this would be too risky," "they won't tolerate this treatment," when actually in reality we don't really know. And so there's lots of scope to improve our understanding so that we can help inform patient care. So just to give some figures to back up this claim of underrepresentation in clinical trials. So there's been quite a few studies across the world to show that this underrepresentation. And actually the NIHR have picked up on this, so the National Institute for Health Research, and older people, so they would say patients over the age of 75 are now considered an underserved group. So which has really triggered quite a wave of interest in this topic to see how we can bring down some of those barriers to engagement in older people with research. And for my own interest, really, I just had a quick skim around some of the big journals and some of the big studies which have been going on in oncology at the moment, trying to see for myself, why is this happening? And I think probably one of the main barriers from what I can see is the use of performance scores as inclusion or exclusion criteria for people being recruited into big research studies. Now, we're just really talking about clinical trials here, obviously, rather than observational studies. But I think a lot of the patients who we look after will not be eligible for recruitment based on these performance scores. So the World Health Organization score and the ECOG, which I know is used day in, day out in oncology. And I think maybe we need to have a period of reflection and have a think about, whether this is actually necessary, bearing in mind that we do want to be our sample that we use for research should really be as representative as possible for the patient group that are going to be considered for these treatments. So I think that's just something to have a little think about. For those of you involved in research and study design and getting studies through from conception to the actual stage of recruiting patients, obviously there's lots of hurdles to get through, and these inclusion-exclusion criteria are put in for good reasons. But I think the general school of thought is that we should be trying to be as open as possible. And really, when we're putting exclusion criteria in, they need to be really well justified. And I think that is a bit of an area for debate at the moment. So there's a few papers in the literature looking at barriers and enablers to clinical trial enrolment of older patients in cancer. And this was one I picked up because it seemed to be quite comprehensive. So I just wanted to run through some of the barriers to research, which I think are important for us all to be aware of. So eligibility criteria we've already touched upon. Performance status is often the key reason for exclusion, as well as multimorbidity and commonly renal function or polypharmacy will act as a barrier for practical reasons for people taking part in research, particularly therapeutic pharmacological research. Concern around tolerability, side effects and toxicity due to aging and physiology. And again, depending on the type of study, that might be very relevant or not. But actually, arguably, that is probably one of the main reasons why we should be including older people in research, so we can better describe these problems and give our patients more realistic expectations to avoid what we call selection bias, which is where if we're only recruiting relatively well patients, then the results are going to make the intervention look a lot better than it actually is in reality. From an ethical perspective, I know from my personal experience as well, when you're going around recruiting patients on the wards or in outpatient clinics, if you have a patient in front of you who you think is, in the last year or two of your life, and you've got a study which is looking at a 5-year follow-up plan, then that there's that ethical question of, well, really, is it appropriate to be approaching this patient for participation in research study where we know they're probably going to die in the follow-up period? But I don't really think we should be worrying too much about that, depending on the trial, obviously. I think the real question is about how burdensome that study is going to be. So, some studies will involve very frequent follow-ups, invasive interventions, lots of blood tests, that kind of thing. So, there needs to be quite a frank conversation between yourselves and the patients about, whether they're willing to do this. But actually, in my experience, in heart failure research that we've been doing, so one of the main studies I'm involved in at the moment is called Triage HF. And this is a remote monitoring study where we recruit patients into a sort of telephone follow-up protocol. And I would say the older patients are actually more keen to get involved than some of the younger patients because they really want to be part of the process of improving care for the next generation. And you really do feel and hear that when you speaking to patients. They'll often say things along the lines of, well, I know this probably isn't going to help me, but if I can contribute to improving care for the next generation, then I'm willing to go for it. And so there is that positivity that comes along with that generation. In terms of time, I think there's no getting away from the fact if you have a patient with poor mobility, sensory impairments, it's going to take more time, cognitive issues, to recruit some of these patients. And in some of the research study, which have got really tight deadlines and recruitment windows, sometimes these patients get lower down the list of priority. But I think, everyone involved in research does understand that, we should be trying to get a good mix of patients in recruitment. Capacity I'll touch on in a second, but that obviously does crop up more commonly in our older patients with cognitive impairment or dementia. But that shouldn't really be stopping us from recruiting patients. So those are all from the sort of researcher side of things. From participants, like I say, although from my experience in recruiting patients, you will find people talking about positivity for the next generation. Also, some older patients will look you in the eye and say, "Are you joking? You don't want to be recruiting me." And it does take a bit of time to explain, actually, no, we really do want to be recruiting you. There's this feeling of not being a good research participant sometimes, which you have to work around. Some older patients just want to be left alone. That's absolutely fine. They see enough healthcare professionals in their treatment. They don't want any more engagement with healthcare. And that's absolutely fine, of course. This idea of experimentation, which is quoted in the literature, although I've not really come across that, to be honest. The idea of patients not wanting to endure any additional side effects or intensive study protocol, and that does come up quite a lot, especially if there's an intensive follow-up protocol for patients, blood tests, scans. I can appreciate how that can be quite burdensome for patients, especially with issues around mobility and transport. Often you'll hear people talk about long waiting times, and it's just too much. So participation burden is a big thing for a lot of our patients. So, having said all that, the NIHR is on a real drive to try and improve. Improve the recruitment of these underserved groups into research studies. And the Include project is a really useful resource online for people who want to get involved in research. There's a lot of resources there to help with advice and some practical tips in terms of how to improve your study design and how to help with recruitment. So this is just a little bit of a snapshot about the kind of things they can help with. So particularly around the study design perspective, they can. This website's got some quite useful tips in terms of how to help lay out your study documents to assist older people with inclusion, particularly around capacity for consent. So just to focus in on that, because I know it's an issue that causes quite a lot of anxiety. Patients who are lacking mental capacity to consent to participate in a research study can still be recruited. There are avenues in which to do that. And the HRA, which is the Human Research Authority, have been really sort of helpful in this area. I know when I've spoken to them about Triage HF, they've been really helpful in terms of making sure the right documentation is in place to facilitate recruiting patients lacking mental capacity. And it is quite common sense, really. If you're involved in what we call a CTIMP, which is a clinical trial where you deliver a relatively new therapeutic intervention. And the criteria are obviously a bit more stringent there in regard to a legal representative. If it's a non-CTIMP study, so that's studies which we would tend to be more involved in, to be honest, on the wards, which might be an observational study or an extension of the sort of test of change things that we do on the ground in clinical practice, or an intervention which is might be a practical thing. So you might be testing a new service or a new piece of equipment. Generally speaking, you can seek advice from a consultee or ask for another independent professional to co-sign on the patient's behalf. It's relatively easy to recruit these patients into studies. And I know this is done quite a lot in COVID, and I think there's been quite a big learning curve through that COVID time where we have been doing this more and more. So I think a lot of the research nurses and people involved in recruitment are a lot more confident doing this now. I would say that although HRA are quite helpful in setting these things up, it does involve quite a bit of paperwork, and it must all be set up in advance. So that can, just to highlight, if anyone's looking to design a study, it does need to be thought about well in advance. So with our patients with dementia or cognitive impairment, they can still participate in research. So a few other things I just wanted to mention. As a few of the speakers have alluded to, geriatricians might use slightly different assessments to the ones that you're used to in research and in clinical practice. So I think there's now a real drive to start using some of these slightly different measures in research. So frailty, as we mentioned quite a few times this afternoon, so I won't go over the clinical frailty score again with you. But these methods of screening and assessing for frailty are evidence-based, and we use them all the time in geriatrics research as baseline assessment tools, but also potentially as outcome measures. And there are many, many frailty scores that you can use. So whatever type of research you are doing, there will be a tool out there that you can use, whether that's a face-to-face assessment, which can be more brief, such as the clinical frailty score, or there are more in-depth assessments, or whether that be a questionnaire that you can get the patient to fill in themselves or do over the phone, or whether it's using electronic health records. There will be something that you can do. And also some of the physical functioning scores that we use that are, not quite the same as the sort of WHO and ECOG scores, but things like the SF36 physical functioning score is a very evidence-based tool and something that we use in our research quite a lot. Some other physical functioning measures, which also come under the sort of frailty umbrella, time to get up and go test, short physical performance battery. These are things that the therapy team, will be quite familiar with, and I think are really useful measures to use in research, and I think have a lot of potential to be used more as outcome measures. So it's just a bit of food for thought, really, in terms of how we can maybe adapt some of our research methodology to an older population. So this is just to highlight some of the tools I was just mentioning, if they're unfamiliar to you. So the electronic frailty index is something that we use in research now. So if you're doing a study which uses primary care electronic health records, every patient over the age of, I think it's 65 in the UK, should have an electronic frailty index calculated in their GP records. So that's a score between 0 and 1. So you can use this score if you're using routinely collected health data for your studies. Gait speed is something that we use a lot in geriatrics. This is quite an easy thing to do on the ward. You only need 7 meters of corridor and to be able to do this. So gait speed is just essentially how fast you walk. And it is a really good measure of physical performance and a really good measure of a really good predictor of mortality and poor outcomes in older patients. So I'd really, have a good think about using this if you're involved in research with older people. Another thing we use quite a lot is a dynamometer. So that's a measure of grip strength. So that's sometimes used in sarcopenia research, where we're looking at muscle strength, muscle function. And that's a very easy thing to do in clinical practice. That's part of the Fried criteria for frailty, which is probably considered the research gold standard assessment for frailty, and something that I use because I think it's the best assessment of phenotypic frailty. So that means, by phenotypic, I mean an assessment of the person in front of you, their degree of physical frailty. And so included in the Fried criteria are gait speed and grip strength, which you can see in the table, and that gives you, a really objective assessment of frailty that you can use as a research standard. Just a few practical points that I've learned along the way when recruiting patients, mainly from clinic. If you're setting up a study, have a real good think about how you're going to adapt your resources to an older population, and for a population with sensory impairment, whether that be through disability. It's if you find these problems out halfway through your research study, it's going to cause you real problems, actually. So it's really important these things are thought about in advance. So just very simple things like having a patient information sheet that's available in large text, having consent forms that allow for patients to consent if they're unable to write. So, usually that will be done through witnesses, signatures on behalf of patients. The HRA are generally quite open to these things as long as it's done properly, but it has to be thought about in advance. Digital exclusion is becoming more of a thing. We're doing a lot more electronic consenting, communication via email, and obviously you don't want to exclude patients who don't have access to the internet or aren't familiar with using these kind of communication methods. Telephone consultations are used a lot in research for follow-up, and we've had problems with some patients, particularly who have hearing loss, about how effective that is potentially going to be. And I would highly suggest, if there's concerns around that, to engage the family early on, because they are your friend when it comes to communicating with patients at home. And we've had a few patients where we've always had a relative around, with prearranged time slots to ensure that we get the information we need. And inevitably that often involves having longer time slots for these patients. So a little plea, please engage with geriatric research. We tend to be a pretty friendly bunch, and I always I don't get many requests for me to come and help people with their research, but there's not many academic geriatricians around, actually, and we're always here to help if you need a bit of advice about how to use geriatric assessment measures for research when you're setting up studies. And there's lots of areas in oncology and in lots of other specialties that require a bit more research. So I think it's already been mentioned, the role of comprehensive geriatric assessment and which patients would most benefit from this. Management of polypharmacy in oncology is clearly a big topic. I think there's lots of scope to do more research in this area. Looking at alternative outcome measures, patient-reported outcome measures, really important in geriatrics. And you'll very rarely find a paper in geriatrics where mortality is the sole outcome measure, or even an outcome measure. We tend to look at patient-reported outcome measures, measures of physical functioning, and measures of biological aging and frailty states as well. And I think that's a really interesting area of research in itself, and how we best measure positive or negative responses for our patients. Cognitive testing, the impact on some of these treatments on cognition and dementia and sarcopenia. So sarcopenia, we talk about muscle strength and muscle function. In older patients, I think are really important areas for research, so we can provide patients with much more evidence-based information about what to expect. So I think that's all very exciting. And I'm happy to say I think this is clearly a hot topic, and there does seem to be a lot of research coming through in these areas. So let's all jump on the bandwagon. I think geriatric oncology is clearly a hot topic in research at the moment. So I think that's really fantastic. So thank you very much. Here's my email. Feel free to email me anytime, really. Always happy to speak to people about geriatrics research. Thank you.
Thank you so much, Jo, for a really interesting talk. And I think, it's really useful for me to learn about patients, including patients without capacity, because that's often a difficult area, isn't it? So thank you very much. And I would encourage everyone to take up Jo's offer of contacting her if you're interested. I must say that we are, as geriatricians, a friendly bunch, but unfortunately, academic geriatricians are like gold dust. So please do, if anyone's interested, do contact Jo. Okay, so I'll just open it to the floor if there's any questions. But before we touch on any questions, I just want to, maybe out of interest, for people to maybe post in the chat about whether they have services locally that we're not aware of, or if there are initiatives locally that's been done, pilot projects, audits around kind of improvement of care for older adults. And it'd be really interesting to hear what you're doing, kind of across the sites in GM. So please do post some of the things that are happening in your areas, and also any questions that you've got for the speaker. So I'll start by picking up some of the questions already posted by the audience. So there's a question up from Samantha about what the biggest barriers older people have when assessing services. What should we consider in our practice? And I think, Naomi, this is probably for you.
Sure. Thanks, Cassandra. Yeah, this is a really interesting one, because I've kind of got two sides to my answer, I think. So the first one is that I think probably the biggest barrier is getting through our doors. I think as you touched on in your presentation right at the beginning, there's something about later diagnosis for older people, and the fact that they don't actually see us for a period of time in secondary or tertiary care. So that's a huge barrier, and obviously that's multifactorial. But the other side to it is that I'm not sure I'd identify sort of huge insurmountable barriers. It's more like lots of little cumulative occurrences that make up a big barrier. So if I explain a little bit more about what I mean, I think it's a lot like the model that Jenny was referring to in her presentation, where you're looking at a balance between deficits and assets. And another way of looking at that is Nathan Shippey's cumulative complexity model, which basically talks about how your workload, as your workload increases, your capacity to manage it also has to increase to achieve that balance. And when you get older, there's a lot of occurrences that happen to both increase the workload, so increase the burdens, whether that's additional health conditions or increasing physical difficulties in functioning. But not only that, there's a decrease in your capabilities or assets, as Jenny called them, because of that. So, for example, your social circle might diminish, your supportive spouse might pass away, etc. So I think it's more to do with the imbalance that occurs rather than a series of barriers that exist to to stop people accessing our services. I hope that makes sense.
Yes, complete. Thank you very much. I think this is a question for Joe, and I think that's a question I have as well about funding for researchers. For example, incorporating obviously funding from drug companies, pharmaceutical companies. I think it is incredibly difficult to get funding for research to begin with, and we rely on our pharma colleagues to help us with that. And Sam's asking a question about how do we get farm involvement to include older, frailer patients if sometimes these patients are the people that make their data look worse, and sometimes not for a bad reason, but and not as the fault directly of the drugs. Have you got any ideas?
Well, there's sort of two sides to that. One is regulation, and the HRA, increasingly now, they won't let a study go through unless you can justify your exclusion criteria. So I think it's getting harder and harder for drug companies to sort of, to get a study through ethics, with exclusion criteria that they used to have in the past, which would be like age cutoffs and things like that. So there's that side of things. In terms of encouraging them to, to go down this direction of travel, I mean, at the end of the day, older patients with frailty take a lot of medicines, and a lot of that's their bread and butter in terms of patients taking drugs. I mean, you talk about polypharmacy in older people. I mean, the costs associated with that are huge, and I mean, in terms of pure numbers, there's just so many older patients with frailty, who could take some of these medications that it doesn't really actually make any sense to exclude them. It would be my kind of sell.
Thanks, Joe. I've got a question for you, Jenny. You talked interestingly about social frailty and the simplicity of doing social frailty screening, just like the CFS. And I just wonder, obviously, the things I said it myself with regards to CFS, there's no point screening someone if you're not going to do anything about it. And I think that's the fear of people doing anything, not because of the time to do the screening, but actually what do we do about it? And we don't want to open a can of worms or have to do, lots and lots and lots afterwards. And with regards to clinical frailty scores, I think obviously sometimes the primary care is already very on board of this, and our primary care colleagues do help when we send this back to them saying, this patient could potentially be frail. Can you help with polypharmacy? Get your pharmacists to have a look, get the dietitians to have a look. But I just wonder whether you've got any tips about simple things that, any one of us could do if someone screens as being positive, that's not too much work.
Yeah, I think I would imagine it's already been covered. If people are doing the holistic needs assessments, then the things that are likely to come up in terms of frailty screening or social frailty screening are likely to be covered within that. So I think it's first important that we're not asking you to, it's not about developing a whole new skills and knowledge. It's probably stuff that you're already doing as well. So for example, if someone referring people to social services for assessments, befriending services, linking them in with maybe groups at the local hospices or with Macmillan and accessing all those services. So I'd like to think that it's not about it's not necessarily about like creating new knowledge and new services. It's already linking into things that we're already doing as well. That said, I think it is about clinicians having that awareness of where to refer into. So some hospitals will have social workers where they can link into, and they can be a point of contact or directing. We've got cancer information services again, which are really useful resources in terms of local groups and local activities within their specific areas. Maggie centres as well. So I think it's about building those confidences, building those links within your existing services to see what's out there so you can direct the patients on.
Thank you very much, Jenny. Actually, and I think we've talked previously about the role of the overlap between the CG and HNA as well previously. I mean, obviously it's not fully equivalent, but they do, as you say, pick up certain bits
Yeah.
of geriatric syndrome, social frailty. So that's really useful tip. There's no other questions in the audience. Don't know if the panel has anything they want to add. No?
No, just thank you very much to both of you. I think it's been a really nice spread today, hasn't it? We've had three sort of, in addition to yours, Cassandra, I think we've had three quite different presentations touching on very different areas. So I think they've complemented each other reasonably well. So thank you.
Yeah, thank you. I think it's been interesting to see how they overlap as well, although they have been very different. There's common themes running throughout them, isn't there?
Mm-hmm.
And I think it's also really very important. I think in setting up services, and I'm sure everyone in the room agrees that in setting up services, it's often very difficult to obtain funding for care of older people, or liaison service. Sorry, I mean in hospitals. Obviously, geriatric medicine is very well embedded, but I think we're never kind of funds generating, so income generating service. The things we do are like, what all our speakers have talked about are improving care in older patients, patient satisfaction, improving their EPROMs, those kind of things. So I think it's really important then for things like research to come along to show the benefits in older people, because it's often I go around saying to people, please could you give us a bit of money to start something? And they say, well, are you saving us money? And you're like, not really. How long are your appointments? 45 minutes. Oh, well, we see 30 patients in that time and you're seeing one. And you need your MDT as well. On top of that, why should we do this? And I think having data from research and an incredibly important, research data to actually prove to say actually improve outcomes in this way, reduce toxicities, and we don't just stop treatment, those kind of things. So, I think it's really important collectively that we raise this up, from clinical service provision, audits, research, education, from all the different hats to raise oncogeriatrics in the national agenda. And I often say to people, sometimes people say, I'm not a geriatrician, I don't look after this kind of patients. But really, you could argue that if you're not a pediatric oncologist, you're probably a geriatric oncologist, because most patients are at both ends of the spectrum. Not to say that there's no one at the age of 30 or 40, but you tend to get the very young and the very old presenting in cancer settings. So this leaves me to thank all our speakers really for the very educational talks. Thank you for spending your time to come and share your experience and your knowledge with us. Also, thank you to all the audience. Thank you for attending. We very much value your feedback. This, as I say, is the first of 2 webinars planned at the moment. I'm hoping that we can plan more educational activities to come, and really want to hear from yourselves about what you would like to learn in future webinars or future education sessions. So please do feel free to email any of us or the GM Cancer Academy team if you've got any thoughts or any ideas, or if you want to present something that you've done locally as well. So we would love to hear from you. So thank you very much. Have a good rest of the afternoon.